A patient asking for a sleep aid is a common phone calls we receive while covering the floors. Should we give a sleeping aid and which one to use is the topic of this video. This is the fourth video of our series, First Week of Residency Tips. The link to the whole playlist is provided below. Let's start. While covering the floor, we don't have the luxury of getting a thorough sleep history or trying behavioral therapy. That's appropriate for outpatient chronic insomnia treatment. In the hospital, when patients ask for help to sleep, they expect to receive medication for that. To me, the hospital is the worst place to sleep in for many reasons. Different environment, different beds, beeping pumps, screaming patients, early morning blood work, and vital signs checks. For those reasons, some hospitals may try to minimize that by adjusting the time for vital signs checks and blood work, having nurses respond to alarms quickly, closing patients' doors, enforcing visiting hours restrictions, and posting quiet signs. Melatonin and melatonin receptor agonists, antihistamine, benzodiazepine receptor agonists, and antidepressants are the drug choices for insomnia treatment in inpatient settings. Melatonin is available in almost all hospitals. It is the first line option. Melatonin comes in 3, 5, and 6 milligram. Melatonin receptor agonist Ramelton is not available in most hospitals' formularies. If it's available, it comes in 8 milligram doses. Trazodone and Mirtazapine are antidepressants that are widely used as insomnia drugs in inpatient settings, despite the fact they are not included in the American Society of Sleep Medicine guidelines. Trazodone 50 to 100 mg is commonly used for insomnia treatment. A lower dose of 25 mg should be used in elderly patients. QTC prolongation, orthostatic hypotension, nausea, and headaches are important side effects of trazodone. Trazodone should be avoided if there is a prolonged QTC or drugs known to prolong QTC giving already to the patient. Mirtazapine at lower doses of 7.5 to 15 mg may be used as an insomnia drug, but it stimulates appetite, which can be good for some and not for others. Before we continue, if you'd like to receive a summary of this video and access the previous video summaries, kindly subscribe to my Substack page. The link is provided below. Sedatives, antihistamines can be used in younger population. I avoid giving it to patients or to elderly patients because of their anticholinergic side effects causing delirium and urinary retention. Diphenhydramine, hydroxyzine, doxylamine 25 mg orally as needed at bedtime may be prescribed. Zolpidem, Ambien is another commonly used insomnia drug in inpatient settings. It belongs to a family called benzodiazepine receptor agonists. It helps with sleep onset and sleep maintenance. Zolpidem 5 mg in females and elderly and 10 mg in younger adults can be used. Zolpidem is the drug of choice in pregnancy and breastfeeding. Among benzodiazepine, Temazepam or Restoril may have the best safety profile for use in insomnia. It is available in most hospitals. Also, it has a quick to moderate onset of action and moderate duration of action. It helps with sleep onset and sleep maintenance. Temazepam 7.5 or 15 mg PO can be prescribed. Now, when a patient asks for an insomnia drug, check if he or she takes something at home and resume it if there is no contraindication. They may sometimes ask for a specific insomnia drug that they took in the past and worked for them. In such a case, we can order that specific agent if again no contraindication. Now, if the patient is not taking any insomnia drug at home and is not asking for a specific insomnia drug, melatonin or melatonin receptor agonists are first line. Trazodone is a second line. Zolpidem comes third. Temazepam and diphenhydramine come last. Always start with the lowest dose available, particularly in elderly patients, and always use immediate release form. Avoid using extended release form in inpatient settings. Now, all sleeping pills should be ordered PRN or on as needed basis at bedtime or QHS, not scheduled. Avoid giving insomnia drugs with other sedatives simultaneously or close to each other. For example, don't give morphine and diphenhydramine at the same time or close to each other. Pay extra attention to obese patients, patients with obstructive sleep apnea, and patients with advanced pulmonary diseases. These patients should be placed on continuous pulse oximetry. Insomnia drugs should not be ordered routinely as part of the order set. Please do not order them unless the patient asks for help to sleep. Now, almost all insomnia drugs may cause, with variable degree, drowsiness and prolonged sedation, which can lead to imbalance and increase the risk of falls. This is more prominent with benzodiazepines, benzodiazepine receptor agonists, and antihistamine, all of which increase the risk of delirium as well. I highly recommend against discharging the patient on these insomnia drugs. If they ask for a prescription and discharge, advise them to follow up with their primary care physician for a more thorough insomnia assessment and treatment. If you decide to write them a prescription, do not give more than 3 days supplies. In the end, if you found this video useful, please give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. And remember that you can get a summary of this video and access the previous video summaries by subscribing to my Substack. The link is provided below. Thanks for watching and see you soon.